Your drill won't do that.
Why did you do that?
It's just old.
Oh.
So, here's what we're gonna do. So, when I have this, and I've determined I'm gonna use it on my patient, number one, I'm gonna make sure my extension tubing is ready. I think I have perfect. My extension tubing is all ready. I have a Sharps container that's all ready to go as well. And I have something I haven't talked about because it's packaged separately, this stabilizing device. So this stabilizer device is only partially done. Maybe you guys actually have a full stabilizer in there which you can look at, but there should be an insert in here that can kind of stick up and go down and can adjust to how your catheter's in. It basically takes advantage of the idea that sometimes your catheter doesn't completely seat in the skin and there's still some catheter showing. This stabilizer will help overcome that. The stabilizer has other features too that make it important. I'll talk about that when we actually get to that point of the skill. So, when I've determined that I'm going to be doing this, number one, when I'm doing humeral IOs, I need to make sure I'm using a yellow needle. This isn't completely hard and fast though. While most of your humeral IOs are going to be done on adults, and most of your adults are going to meet the qualifications to have the yellow done on them, there's always that question of, well, what happens if I'm dealing with that person who's emaciated, that person who's small, that person with pre-existing medical conditions that limits how big they are? Basically dealing with a small adult. Well, the cutoff is here, and I wish there was more literature that preached it, but I just got this from the last training. Basically, you would use this needle in the event that your patient was under 80 pounds. So there you go. That's when this will be used. I'll also note with you guys, it's not really pertinent as of this moment right now, since we're not in that block area, but the humeral IO is a spot for people who are greater than 8 years old. Outside of that, the area isn't developed enough to be felt. Therefore, you'll know you can't do it on a 7-year-old because you won't be able to feel where the humeral head is like we just tried to do on each other. So again, it's contraindicated because you can't feel the anatomical location, but because of their stage of development, that's why. So if somebody's 8 or above, we can do it. If they're under 80 pounds, we find ourselves using this one. And if they are basically your average adult size and bigger, this is the size we're going to use. What you're going to do is you're going to find your spot, get the correct positioning, and you will anteriorly feel where that humerus is. And then once you feel it, I take my needle and catheter and I put my fingers over it this way. I do this because there have been instances where people will unscrew them, as I brought up before. So if we do it this way, I keep it stable. Well, this thing will fall off anyway because of how old it is, but this will keep me from accidentally unscrewing this in the heat of the moment and being shaky and taking off my catheter and putting a stylet directly into the bone. I've seen it happen. It does happen. It's happened enough to where even Teleflex is aware of it. Next, what I'm going to do with this here is I'm going to use this to do my little spot of demarcation. Basically, I'm going to blanch, whiten the skin of where this is going to go. If your patient needs definitive therapy, it shouldn't be a tall order to do. Once I have that location marked, I'm going to go, okay, the angle I'm going to go in for this patient is going to be right here. This is where I'm going to go, and you can see a little mark of where you're going to go. Now, what you'll do after that is you'll get your alcohol prep, you'll clean that spot, and then once that spot is clean, you'll take the catheter off. My fingers are still on this. This helps remind me that this thing needs to stay on. Now actually I have to hold it on just because it's kind of an older one. And then I'm gonna go ahead and put my thing right into where it, my mark was, and then I'm gonna look. I'm gonna make sure my angle is pointing towards the opposite hip, that I'm 45-degree angles from the head and bed, which should roughly mean the same thing, just two different frames of reference. I'm gonna make sure that I can see a black line, and then as soon as I have all that, I completely sink it to the hub. That's what I do for this one. I completely sink it to the hub. You do not feel for a pop. You don't do any of those things. This isn't a growth-dependent bone. The medullary space isn't as thick. Unless you're Arnold Schwarzenegger, Rob, this thing should be a very easy area to get into, thus easy to penetrate, and that's why it receives so much fluid. Now, when I'm taking the stylet out, I hold onto the hub. As I hold onto the hub, how well it's seated in here will give me an idea of whether it's good. The first check of an IO being good is that this thing doesn't move very much. It shouldn't. If it's in a bone, it's gonna be just like you put a nail into a piece of wood. That's what's gonna happen here. Now, I hold it to pull the stylet out, but I don't need to keep holding it. This thing is fine just the way it is. I will go ahead and sharp. I sharp like this because I'm used to backs of moving ambulances, so I always move as a unit to do these types of things. So that's how you'll see me going. You guys will practice the sharpening. I'm gonna have you sharp the whole system though, just so we can get through more reps of getting this done. But concept is still the same. Now the next thing I'm gonna do is, I haven't checked it completely. I know it's seated there, so my first step is good. I'm gonna take this, and I'm not gonna take this stuff off. I'm gonna leave this on. I'm gonna put this on just like so, and it's gonna lock around here. Because of this inner system that isn't present in this particular thing, it's hard for me to kind of illustrate it for you, but it should groove in and situate so it secures either side of the catheter. Once that's done, I'm gonna leave the adhesive, the cover for the adhesive still. I don't wanna actually remove that yet because I'm not 100% certain this is good yet. I feel good, but let's make sure it's okay. What I'll do, we would leave it on. I just don't want to get it in the way. I want you guys to have a good visual. I'll then take my system that I have set up, and I'll go ahead and thread it on just like so. And I'm gonna go ahead and draw back. Sometimes breaking the medullary space might be necessary first. Sometimes it isn't. Like I said, this isn't like the tibial where you actually have to break it a little bit before you pull back. This space is gonna be a little easier to deal with. It doesn't, and adversely doesn't cause as much pain. I'll talk about the conscious patient in a second. But when you draw back, you should see yellow, you should see red, and if you are able to draw back, but you're not seeing any of those colors, that's okay. Remember, different things cause different people to be in this type of circumstance, so just because you don't see something doesn't mean it isn't there. So what you're gonna do, or isn't in the right spot, what you're gonna do is flush it some more, and then pull back, attempt to see it again, and if not, again, we still have one more final check we can do to make sure that your device is exactly where it needs to be. So we'll remove this, we'll attach medications, we'll use a pressure infusing bag to give the fluids to the rate we would like to give the fluids, and then you'll begin your pharmacological therapy, the reason you did this in the first place. What you should see in a patient with a good IO is the pharmacological changes. If I gave somebody sodium bicarb, it causes a bolus of CO2 out of the system. That's what bicarb does. So if I gave bicarb, that's what I should see. If a patient's in PEA and that patient received epinephrine, well then what's it gonna do? It's gonna increase the rate of the PEA, right? Or maybe increase the heart rates. If somebody was in a dysrhythmia of some kind and I gave a pharmacological antidysrhythmic, then I should probably see a change or an abatement in that. Those are the things that you'll look for when you give this, when you utilize this. Flow is very good here. Like I said, 6 to 7 liters per hour is what you can get with a properly placed IO. Now, once you've confirmed that this thing is good to go ahead and you'll secure the stabilizer. Now this stabilizer isn't something that typically is needed to keep this thing protected from falling out. It should be there. If it's in a bone, the only time it falls out is if it's not in the bone. Like if you're between the bones, like if you went into the chromium or you went into the patella or something like that with the tibial. If this thing is in a bone, it's good. What this protects the IO from is lateral impacts, such as EKGs or other pieces of equipment that would knock into it. This shear, the path of least resistance in this system is gonna be this thing right here. This is the thing that can shear it off right there at the hub. So that's why you get this on, to protect this from us. In the hospitals, this is actually a big deal. It happens more there because they have more time with the patient than we do. They need these things because when patients are shifted around from room to room in the hospital, this thing is gonna protect this thing from when that equipment gets thrown between the patient's legs. So this does have a purpose. It's not just a cash grab for Teleflex. Now, let's talk about this now. What happens if you have a conscious patient and you're doing this skill?
Lidocaine.
Lidocaine is what you're gonna do. So now let's rewind all the way back to when I got this thing in there. Once this thing got planted in there, I need to check to make sure it's good. I'm gonna switch the steps up. I can put that thing in place, the stabilizer in place, and it's recommended to still put it in place, not fully secured. You can check the medullary space a little bit with this, but again, you're playing with fire as to if it's good. What you are better advocated in doing is getting your lidocaine. I would recommend wasting the lidocaine to the amount that you need, which is 2 milliliters. That's the volume that you need to see here. You should see 2 milliliters. That's 40 milligrams total. The goal here is to be a local anesthetic. You need to anesthetize the medullary space so that it doesn't hurt this patient as much. It's uncomfortable because you want to do stuff so quickly. You're doing this for a big definitive reason, but here's the deal. This is a very uncomfortable skill. Not as uncomfortable here as it is here, but it's uncomfortable nonetheless. So what you're gonna do with this person is you're going to give this twice as slow as we would normally give it. You're not on the hook for Lido yet. Lido is given typically 50 milligrams a minute. That's how fast we give it. In this patient, you're gonna give it twice as slow. Effectively, you'll be giving 2 milliliters. Like I said, waste this to 2 ml so you don't screw up. And you'll give those 2 mLs over about a 4-minute period. I don't care about the state of the patient or any of that stuff. If the patient loses consciousness, then I stop doing this stuff and I do what I want to do. But until that moment happens, it's not ethical to not anesthetize this area to make it so they can tolerate the next treatment. It is not pleasant. The pain sensors, the nerve sensors, and the endings that are in here, they're pressure oriented. So when you apply the pressure into this confined space, it causes a cringe-worthy amount of pressure, pain, and sharpness localized to this area and then systemically. It can be very painful. Here, more of a discomfort is what's been noted by most patients, but discomfort nonetheless. Here, it's cut my leg off, please. I would prefer that than whatever it is you're doing down there. Or even worse, I've heard it firsthand, let me die. I'm okay. I've lived a good life. Is it worth it? And if this is the last thing your patient receives, in which case it sometimes will, consider that too. Regardless of what you do, there is sometimes medical futility in the stuff that we do, but we're still gonna do it because there's something that we can make a difference in. If this is the last thing they're gonna remember, maybe you should at least make it ethical for them and treat the pains and discomfort they might experience and give yourself those extra couple of minutes. It's an uncomfortable period of time, but I recommend it for you guys. Okay. Do you guys have questions on the humeral IO?
Would you give like fentanyl and ketamine before?
Not before. You can't preemptively treat those pain states. You can only locally anesthetize the area, which is what Lido's doing in this case. It's meant to be local. The slower you give it, the more it can penetrate. And it's even recommended in some cases as you're giving the lidocaine. And I don't know if I stated this more aggressively, but I'll demonstrate with the Lido. You connect directly to the hub. You do not load the extension tubing. It goes on just like this. There'll be a stabilizer here, maybe a stabilizer that isn't done. You can check the integrity of that IO by pulling out into it, or maybe you could have checked it with this and then taken the extension tubing off. Either way, you're going directly into the area you're trying to numb up. Just like if you went to the dentist, you'd want the dentist to do that for your teeth before he starts rolling around and they're screwing with your teeth, right? Same thing here. Before you start messing around in the medullary space, this is exactly what you're gonna do. And it will be slow. And sometimes you can give half of it, maybe 2 minutes, you'll give the first ml, you'll take this off, flush a little bit, nice and slow. That way you can break down a little more of the medullary space and then get the rest of it in there and get a couple more of those nerve endings that you wouldn't have gotten otherwise. Yes?
Will you always get flow even with a bad IO?
With a bad IO, you will get flow to a certain extent, and that depends on how you caused extravasation. So when you're dealing with the IO, and I'm using a stylet to demonstrate this, sometimes you find yourself here. Sometimes, in this case, I'm using this more in line with what a tibial tuberosity is, because the angle that we do on this, it is almost impossible for that type of thing to happen. But in like those tibial IOs, this is what can sometimes happen. If you used a bigger thing or you didn't feel for certain things, I'll show you guys in a second, you're not going to get any flow because you're inside a dense space, and whatever porous stuff is happening here, they're capillary level. You're not going to get any flow at all. Now, what will most of the time happen isn't that. This is what's going to happen. You go through and through. When you're dealing with this one, it's hard to do that, but when you're dealing with tibial tuberosity, it goes from a big area, well, relatively big area, and immediately into a small tube known as the tibia, the shaft here. And there's a huge difference. And here, this space, depending on what structures it might be in, it'll flow. It'll flow for a little bit until it doesn't, but you'll find extravasation. You'll see the swelling. You'll feel the swelling. Those are all things that you're going to look for, just like you would with the bad IV. Those are things that might be noted in the moment you find them. Just like with any other vasculature, you cease and desist, you pull it out, and then you move forward with the next thing that you'll do. Okay. Alrighty. Let's jump the tibia, and then I'll have you guys do this. Now, the tibia is plan C. I guess you could say it's plan D or plan E because you have all these other different things you can do. Or maybe not plan E, we'll say plan D. The tibia is more distal. So it takes a little longer for stuff to get there. Where this stuff dumps into the subclavian or very close to the subclavian and into the greater vessels, this one actually has to go a little bit through circulation before this stuff gets to where it has to go. Now, the way you find the landmark when you're doing the tibial tuberosity is you're gonna palpate from the bony prominence that's just below the patella. So I'll show you on my leg here. What you're palpating for is you're finding, in here it's a little easier to show just because my leg's bent, and bending the leg can sometimes help you find the different features of the bony prominences. But when you do that, you find where the patella is, and once you find the patella, you find the middle where the bony prominence seems to meet it, and then that's where you begin your count. That's where you take your 2 fingers, or roughly 2 inches. Those areas end up being very close to each other, but those are the frames, about 2 inches down, about almost 2 fingers, and then 2 in. That will typically get you where you need to go. I want to emphasize something here. The tibial tuberosity, unlike this other one, it's growth dependent, which means the longer it's used, the more it's used, the denser it's going to be. All of us have very thick tibial tuberosities, which means it's going to hurt that much more, and it's going to be that much more difficult to flow fluids through them. We have to overcome that through breaking that medullary space. That's the dangers of this part here, or rather the pains and the issues that we see with this. That's the thing that would typically say, we need to get an IV before we get that IO. Now, when you palpate this area and you palpate down and palpate over, you should all readily feel a rough area that's flatter and bigger than most of the other areas of your tibia in relation. That's going to be what your landmark is. And unlike the other one where above the waist it's 45 degree angle, you're going to be hitting this one at a 90-degree angle. Now, while this one can get you to the right spot or the rough area you're going to be in, sometimes we can't rely on it because being a growth-dependent bone, sometimes the tibial tuberosity isn't as well defined. You're not dealing with a diameter that's very different than what you're seeing on that humerus there. It just happens to be very thin all around just based on those features. How long has that person been in that skilled nursing facility, so on and so forth. So here's something else you can do. You can try bending that patient's extremity as well. And it doesn't require a bend like this. It's just a subtle bringing up of the patella to define the upper features. And that will help you take your fingers and you can begin the process of palpating up. Find the outer rim of where the patient's tibia is and begin the process of palpating up. As you palpate up, you can sometimes feel the exact moment where the tibia tends to get wider, and that's the bottom rung. Think of that as like the bottom of the pool. You can't go any deeper than that. This is as low as you could potentially go to still be in the tibial tuberosity. You'll get yellow if you go close to where those fingers are, but you'll still be in the right spot. That's the goal here. That is the lower limit. So if you take this and then you match it with what you have here, you can then find, oh, I'm right here. This is my window that I can perform this skill in. Final thing with this is it's big toe IO. To help you remember, you are going medially. It's not lateral, it's medial. Big toe IO. That's where this is going to be. Those are 2 different ways that you can work together to find the location you need to be in. Now, like I said, being a growth-dependent bone, one area is very thick and you can work with it. The other area, not so much. That means that you're going to have to be very, very careful with how you perform the skill. Whereas the other one is just drop it like it's hot and sink it to the hub and you'll be fine. This one does not function that way. This one requires you to be very careful and be mindful. Once you have your location marked, you're going to make sure you follow the same steps. Let's gotta try and change this. I'll do this after we finish this little demonstration. So what you'll do is you'll find your equipment. In a patient who looks like this, sticking with the standard blue, this is totally fine. This will probably be the tool for the job. I'm going to follow the appropriate steps, and if it isn't, I'll adapt accordingly because I have it in my IO kit. I'm going to slightly bend the patient's leg. I'll find the defined area of where this knee ends. In this case, you can see it in this bony prominence right here, and where we go over, we can see exactly where we're supposed to be. This is going to be my window here. Now, once I'm there, I'm going to mark the area. Then I'll make sure I clean the area off. I have all of my stuff ready. I have my sharp shuttle nearby. And then what I'm going to do is I'm going to go get my needle and I'm going to, gotta be careful here so it doesn't fall off, penetrate down, and it's a 90-degree angle. I'm already falling into a hole, so I'm going to try to pull back a little bit just so you guys can see. There we go. That should be right on top. Now, what I'm gonna do is I look. If I see one black line, I'm good to go. I can proceed with the skill. But like I said, I kind of fell into an already established hole here. This mannequin's old and crummy. I apologize. But if I saw this, I can't use this needle. This is a good example of when I would have to go to yellow needle. That's why we check. That's why we stop. We don't just poke the skin and start the skill. We poke the skin. Do I see a black line? Oh, nope, I don't. This is where I would go to the yellow IO needle. But I know this mannequin's fine. It's just because I fell down one of the holes that were already made by another student. This is fine. Once I'm seated on top of the bone, I'm lined up, I have my right angle, I can see a black line. The next thing I'm gonna do is very specific. Of course, I'm gonna squeeze the drill and push, apply pressure to get it in, but it's different than this one. This one's gonna have more pressure. This one's gonna require slightly more pressure for me, slightly more pressure. But more important than that even, is it's gonna require consistency. If I let go on and off the trigger, I do one of these, you will fail the skill if you did a tibial IO with me. I want you guys to know that because this is a narrow margin of error. We need to be very careful here and make sure we're in the right spot. When you do this one, you have to full send it. That means pressure, and then as soon as you feel a give, that's when you stop. That means you can sometimes see in real patients a void space between where this catheter is, and in other patients, you don't. But that's what you guys need to remember. We need to make sure, because if you don't do that, you don't know if you're right here based on a person's anatomy. You have an idea that you might be right here, but you don't know if it's this much space. You don't know how thin this thing is. This isn't as forgiving. So that's why you have to feel for the pop. You'll feel a give. The moment you feel the give, that's where you pull back. So again, consistent, slight pressure is how you'll be successful. Feel the give. Do not start and stop. If you start and stop, I'd almost venture to say that you shouldn't use this one at all. Now, once done and you have it secured, you'll go by the same processes of checking it out. Understand that it's not going to flow as quickly, but it still should flow well. And it's still factory recommendation that you do a pressure infusing bag once everything's said and done. All right. I think I hit everything. Most of the other stuff, we can handle the other stuff in demonstration. Do you guys have any questions?